Good afternoon or early evening for some of you, maybe morning for some of you. I know people are joining us from all across the US and some folks even outside. I want to welcome you to the NIH OITE Mental Health series focused on a variety of topics around mental health for biomedical scientists. And this is our third year, and I know that we have tackled a lot of difficult and important topics. I know there's been a lot of important discussions in the small groups. People have talked about their own struggles, things that they've seen other folks in their research groups and in their communities and in their lives struggle with. I know we've talked a lot about successes and strategies and how we can support each other. And I think that it's a real testament to the community that we gather each month to talk about these important topics. I think no other topic brings up as much emotion as talking about suicide awareness and suicide prevention. I think all of us have so much fear around the topic, pain, for some of us based on previous experiences. It's just a really tough topic. But the thing is that until we talk about something, it just sits in the dark and the fear grows and the inability to talk about it grows. And so I'm really pleased to see you join us today, and I really appreciate it. Each and every member of the biomedical research community is an important part of our community, and each of us comes into work every day, week, month, with whatever's going on in our lives and whatever struggles. And sometimes we really do find folks in a place of hopelessness, and suicidal thoughts come up. And we all need to be able to take caring and compassionate action to open our mouths and find the right words. And so today I'm really honored to introduce Lisa Horowitz from NIMH and Maren Rieger from the NIH OITE wellness staff, who will share the virtual stage in talking about detecting and managing suicide risk in the workplace. I want to thank those of you who have been coming regularly, those of you who are here for the first time. It's really wonderful to welcome you, and I really appreciate you being here. So Lisa, why don't you go ahead and take over from here?
Sure. Thank you so much, Sharon. So yes, this is a very heavy topic, and I'm going to show you some stats about suicide at first, but this is really a talk about hope and action, because as you said, Sharon, there's every single one of us can make a difference. And I think our take-home message here is, how do you start this very hard conversation? Because starting to talk about it is the most important thing. I also want to just start by giving my condolences to anyone who's lost someone to suicide. There's nothing easy about this. And, you know, suicide is potentially preventable. I just want to put that out there, but we're trying to give some ways to actually, you know, make a difference. So I'm going to discuss suicide from a public health perspective, and then talk about some methods that we've been studying for detecting and managing suicide risk, and then talk about strategies that you can use that when you find and encounter someone with suicidal thoughts in your professional setting, and then hope to develop skills, help you develop skills to appropriately respond to a colleague who might be at risk for suicide. So I wanted to put suicide into a public health problem perspective first. So in 2020, you know, that's no surprise that COVID was the main public health problem, and it was responsible for, sorry, this slide got a little bit cut off. It's more than 35,000 deaths, about 135,000 deaths, and 960 per day. And for young people, that was about 10 per week. And then motor vehicle accidents, about 43,000 deaths a year, 118 deaths a day and 20 deaths a day for young people. And then if you look at suicide, you might be surprised to see that suicide as a public health problem fits in between motor vehicle accidents and COVID, with responsible for 46,000 deaths in 2020, 126 deaths every single day, and 18 deaths a day for young people. So what do we do from a public health problem perspective for these things? Well, for COVID, you couldn't go anywhere without seeing something about wearing your mask, social distance, get your vaccine. And this public health outreach actually reduced morbidity and mortality from COVID. And then motor vehicle accidents, well, fasten your seatbelt started out as a public service announcement, then it became a law. And now there's drinking and driving laws. Kids can't get their license until they take driver's ed. Fasten your seatbelt is a law. So, and this public health approach reduced morbidity and mortality from motor vehicle accidents. But if we look at suicide, I'm sure a lot of you are not familiar with this lifeline sign about the suicide lifeline. And that's because mental health as a public health problem is still very much stigmatized, and especially something like suicide. So there's so much more we can do from a public health problem perspective. So let's just look at, in 2020, suicide was the 12th leading cause of death. Again, over 45,000 Americans, and this is over time, and we saw a tiny dip in 2020. But that was not true for younger people. And it is the second, sometimes for some age groups, third leading cause of death. And, young people, 10 to 24, they're not supposed to die. They're supposed to grow up and live long, healthy lives. But in 2020, if you look at the total number of young people who died, 17% of them were from something that is potentially preventable, suicide. And so this gives us a lot of room for how can we reduce these numbers. And I'm including 10 to 24-year-olds because especially on the NIH campus, we have research assistants, ERDAs, trainees who are under the age of 24. So it's really important to be aware of this. The other thing it's important to be aware about is there's disparities in the suicide rates. And there's significant disparities by race, ethnicity, sexual orientation, and gender identities. And what's important is that these disparities are not stemming from the identities on their own. They really reflect more systemic inequities and barriers to healthcare. So I'm just going to show you some numbers. So this is across the lifespan. And this black line is American Indian Alaska Natives. And you can see that's a big outlier. American Indian Alaska Natives have the highest rate of suicide compared to any other race or ethnicity. And Black youth right now have the steepest growing, have the biggest increase in the suicide attempt rates than any other race and ethnicity. And when you look at the single state study from Maryland, and you looked at early COVID and you compared Black residents to white residents looking at suicide, you saw that the rate, this orange line for white residents dropped, while the rate for Black residents actually doubled. So there's significant racial disparities. And not only racial disparities, but people who are LGBTQ plus individuals, or people with neurodevelopmental disorders like autism, or people who live in rural areas. And one of the things that we believe in my research group is that screening for suicide. And when I say screening, I'm talking about giving screening tools in the medical setting, but I'm talking about starting the conversation in non-medical settings, that this really asking can really help identify someone who's at risk. Okay, so when you think about any kind of mental health problem, everybody has symptoms sometimes of depression, anxiety, but when something affects functioning, that's when it changes over from, something that's a symptom to something that's a problem. So not getting out of bed in the morning, not showing up for work, not doing your work, someone not doing their work and getting it done like they used to, or their appearance all of a sudden looks different, like they're disheveled and they're not, engaging in their usual hygiene, or they're in an irritable mood. Irritability is another risk factor for depression and suicide. Their sleep is different. They're isolating themselves. They might be increasing substance use, and then talk of death or suicide. These are all things that might be impairing functionality, and they might be clues that someone needs help. So if we look at the spectrum of suicidality, we can talk about the passive thoughts of dying all the way up to higher intent, active plan where someone ends their attempts to end their life. So passive thoughts might be, if I went to sleep and didn't wake up, I wouldn't care. And active thoughts might be, I have a gun at home, and when my wife and children go out, I'm going to kill myself. And the problem is that every piece along this continuum has been linked to death by suicide. So even if someone's having passive thoughts, it doesn't mean they're not still at risk. So this is just the definition of suicidality: is any thoughts or actions related to volitionally ending one's own life. And even if someone who is thinking about suicide, even if they're not going to die by suicide, anyone who's thinking about suicide is really in emotional distress. It really can take up a great amount of energy, of real estate in your brain. And these people who are thinking about it need help for sure. So these are the risk factors for suicide. I'm not going to go through each one, but the most potent one is previous attempt. So anyone who's tried to attempt suicide in the past is more likely to attempt in the future, right? We have a saying in psychology: best predictor of future behavior is past behavior, and this is absolutely true for suicide. And then mental illness. The majority of people who die by suicide have a diagnosable mental illness. However, there's still a good percentage that don't. And then I highlight medical illness because this is where our research group has focused. Medical illness is often an overlooked risk factor for suicide. Now, if you look at these risk factors, the majority of people who have these risk factors are not going to die by suicide. And that's because they're risk factors, right? So let's pretend you're a triage nurse in an emergency department, and someone comes up to you with risk factors for a suicide, for a heart attack, right? Let's say they have a family history of heart attack, they're a smoker, they're obese, they have high blood pressure, high cholesterol. If they walk up to your triage desk, you're not going to think, oh, they're having a heart attack. But if they come in with warning signs, like let's say they're clutching their chest in pain and sweating profusely, you're going to think they're having a heart attack. So we think of the same thing for suicide. There's risk factors, but even more important are the warning signs. And so these are the warning signs that the Lifeline puts out. And the first one seems really obvious, right? Someone talking about wanting to die or kill oneself. But this one is often ignored, right? Because we even have turns of phrases in the English language, like, oh, I'm going to kill myself, or people say it like that. But what happens is talk about suicide is often overlooked or ignored. So it's important to pay attention to somebody who's talking about suicide. Someone who's looking for ways to kill themselves or feeling hopeless, trapped, or like they're a burden, excessive use of drugs and alcohol, or the symptoms of depression, sleeping too little or too much, withdrawing. These all might be warning signs that someone's at imminent risk of suicide. Okay, so I laid some very sobering statistics on you about suicide, but like we talked about in the beginning, this is a talk of hope and action. And I feel very fortunate to be part of a research group that's in the intramural program that says, can we save lives by screening for suicide risk in the medical setting? And we believe the answer to this is yes. And one of the reasons why we picked the medical setting is because the majority of people who die by suicide, and this is young people and older people, have visited a healthcare provider months, sometimes weeks before they die. And you would think this is a great opportunity to identify and then get someone help. But the problem is people show up at their doctor's office with somatic complaints. So if someone doesn't ask them directly, are you thinking of killing yourself? They most likely won't talk about it. And so the majority of suicide attempters pass through the healthcare settings because the majority of healthcare settings don't screen for suicide risk. Now this, I'm talking about the medical setting, but you can also say, well, a lot of people who think about suicide pass undetected in their workplace, right? And again, it's because someone might notice something, but is too worried about bringing it up or talking about it. So that's what I think that's the analogy here. So what's the most common concern that people have, and this is the biggest myth of suicide, is that you can make it worse, that by asking people questions about suicide is you're actually going to put the thought into their head. So I can tell you that this is not true. This myth has been debunked. You don't have to take my word for it. There's at least 4 studies showing that, in fact, it's the opposite. The best way to help someone who's thinking about suicide is to ask them directly, are you thinking about suicide? And then really listen for the answer and then get them help. Okay, so my research team asked, what are the valid questions you can use what questions can people in the medical setting, nurses and physicians, use to screen medical patients for suicide? And I want to just talk about the difference between screening and assessment, because screening is a very rapid way to identify someone who needs further assessment, right? Further evaluation. Assessment is a more comprehensive evaluation. It confirms the risk and it guides next steps. So when you're asking questions in a way, that's kind of like a screening, but you're not expected to assess for suicide risk unless you're a trained clinician. And even then it's really hard, but starting the conversation is the most analogous to screening. So we created a tool with really good sensitivity, true positive rate, really good specificity, true negative rate. And this is a tool called the Ask Suicide Screening Questions, or as we call it, the ASK or the ASQ. And it's very blunt and it's very direct. And I'm showing you not because we expect you to screen for suicide risk in the workplace, where, if you're not a clinician, we're not asking you to do that. But these are questions that you could use if you wanted to. So they're good questions to keep in mind if you wanted to start the conversation or even continue the conversation. So in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? And in the medical setting, if the patient says yes to any one of these questions, we ask a 5th question, are you having thoughts of killing yourself right now? Now, we are rolling out screening in the clinical center. It's happening since 2017 on the inpatient units, and we're about to roll it out in outpatient. So again, I'm showing you this not because we expect you to use it. That would be hard for a supervisor to pull out a screening tool, but these are good questions. They're very direct. These are good questions to ask. Okay. Now we know from big data, like even I'm thinking of a hospital that's given 90,000 asks. We know that the majority, like maybe 97% of people you ask or you give this screening tool in the medical setting are going to be negative, right? It's going to be 20 seconds and you give 4 questions. But there's 2 ways to screen positive, acute and non-acute. So anyone who answers yes to any one of these questions gets that 5th question. If they're no, they're non-acute. If they're yes, they're acute. Now, acute is an emergency. That's when someone's at risk right at that moment. And it's okay in the workplace that if you're really worried about someone, to say, are you having thoughts of killing yourself right now? That's an acute emergency. That's where you don't leave someone alone and you probably most likely are going to send them to the ER. However, the majority of positive screens are non-acute, and that's really important to understand. So when you look at these 90,000 patients from this big hospital in Dallas, Texas, 99.5% were non-acute, and of the when someone screens positive, 0.5% were acute. Okay, so what happens when a person starts talking about suicide, right? What do you do? Well, here's what should not happen, and this is almost as important as what happens, is You can't treat every person who has a thought about suicide like it's an emergency, right? Because what happens is there's people who have chronic thoughts about suicide, or like I showed you, the majority of people who have thoughts about suicide is not an emergency. You want to pay attention. But if you send everyone who thinks about suicide to the ER, they're going to end up in a paper gown with their clothes taken away. They're going to get a costly one-to-one sitter. And this makes someone feel like they're being punished for actually opening up and talking. So in the medical setting, we have pathways. So we have a way to make screening feasible. In the workplace, we also have some ideas of what you can do. So these are some ways, and Marin is going to talk a lot more about that. These are some ways to engage someone who you might be concerned about, right? So what can you say? Because that's really hard. And it's awkward. And so I'm going to just put it right out there. It's awkward for everybody to talk about this. I notice you have not been yourself lately. Is there something bothering you? I know you feel awful right now. I promise you won't always feel this way, but can you tell me how you're doing? So what someone wants from you is to not panic, right? They want to be able to tell you and have you listen, and then be the bridge to getting them help. Okay. So I'm going to just end my part with one of my favorite quotes: don't let perfect be the enemy of the good. The difference between doing nothing and doing something is an infinite difference. But the difference between doing something and doing something perfect is really barely noticeable. So every single one of us, like you can use those sobering statistics to be a call to action, right? Every single one of us can make a difference just by starting the conversation. And you don't have to do it perfect, and you might trip over the words, but at the end, if you reach out to someone who is thinking about suicide and you give them a chance to open up about it, you could save their life. And so that's really important. Okay. So if we have more time at the end, there's a video that I might want to show, but I'm going to pass it off to you, Marin, for now.
All right, thanks so much. I want to make sure I introduce myself. Again, my name is Marin Rieger. I'm a wellness advisor here at OITE, and I'm also a clinician. I'm a therapist in private practice, and I'm very interested in major depression and substance abuse. And that means that I end up having a lot of these conversations about suicidality, suicidal ideation, and I come to you with a lot of practical experience on these difficult conversations. So I want to make sure I point out, one of the key points that we really hope you walk away with today, which is that we have ample research showing that even a brief intervention, a brief conversation can save a life and can therefore really lower these suicide rates that are such a problem. So we just want to make sure we hit home that point, that one person can really make a difference. And again, I love the concept that we shouldn't let the perfect be the enemy of the good, because we can really make a difference here. All right, next slide. So I want to talk now about this kind of concept of suicide ideation, which if you don't work in the field of therapy or clinical mental health services, it might be a foreign concept to you. It really just means the thought or concept of thinking about suicide, thinking about following through on a suicide. And as Dr. Horowitz pointed out, it's really a spectrum, right? So on the lowest end is someone just kind of thinking about death and dying. And the truth is, a lot of people struggling with mental illness, struggling with major life disruption, medical illness, insecurities, and social cultural problems do think about dying at some point. And it's common in that way. It doesn't mean that we don't treat it as serious. We should always treat it serious. It just means that we don't have to panic, and we don't necessarily have to have the reaction we would have on the other end of the spectrum of suicidal ideation, which is someone who has a plan, has means, intent, and has tried before, right? Has attempted before. All those factors make put someone in a category of needing emergency help. And so it's important to think about that. It's important not to panic if you end up in one of these difficult conversations that we're talking about, but that you just kind of stay aware that if you end up in one of these conversations, which we're going to talk about, we hope that you will have some knowledge now and some ability to figure out where that person might fall on the spectrum. All right, the next slide just hits home this concept that we're talking about, right? So just giving you an idea of how many people have had thoughts and do have serious thoughts of suicide, and then less so have a plan, which really increases risk if someone has a plan, and then has attempted to follow through with a suicide. Next slide takes home the other key point that we really want to make sure we stress, which is that talking with someone about suicidal ideation does not put the idea into their head or make them more likely to follow through with suicide. It actually does the opposite. And we have ample research to show this. It's a really common concern. It's one that myself and Dr. Horowitz hear a lot. And one of the big fears that kind of prevents people from having these conversations is this fear that you'll put the idea in someone's head. And so we just want to make sure we reiterate, lots of research tells us that that's just not true. All right, so the next slide talks about this conversation, right? The conversation that is asking about suicidal ideation. And, again, we don't expect you to go out in any environment at work and look for these conversations. But the truth is, you might find yourself in a conversation where it becomes very apparent that the person that you're talking to is really, really struggling. And, in an ideal setting, everyone would have unrestricted access to a therapist and would not have any barriers to seeking mental health services, but that's just not reality. The reality is a lot of people who need help do not end up in a hospital or in a therapist's office. And that's why it's so essential that we find ways to kind of identify these people and then guide them to getting more appropriate mental health services. And so the goal you will have if you have this conversation is to find out if someone's really, really at risk, if you have reasonable belief in your conversation that they may be, and then to direct them to help. So if you are going to ask this question, you would want to have enough information to believe the person might be at risk and acknowledge it's a difficult conversation to have. And then don't ask it as if you are looking for a no answer or that you're leading to any particular answer. The truth is, this question needs to be blunt and direct. As you saw in the screener Dr. Horowitz presented, it needs to be blunt and direct. It needs to be clear because we need a clear answer, right? If we're asking this question, it's important to be straightforward and not to use softer language, but just to come out and ask it. So next slide, let's talk about how you might do that. These are kind of the goals of how you would want to maintain your composure if you're having this type of conversation with a colleague. Limit questions to gathering information, try to remain calm. It goes a really long way to display calm on the outside, right? You can feel really anxious on the inside and still do your best to remain calm on the outside. And using open body language, making eye contact, these are all skills that will really serve you in this type of conversation. So the next slide talks about more clear directions on this if-then kind of deciding to ask decision tree. So I want to use this to give you hopefully more clarity on how you might approach this conversation. And the truth is, we see this a lot at institutions like NIH and outside of it, where particularly maybe a leader or a mentor needs to have an important conversation with someone in the lab or the research group. And the conversation might start out about work performance and skills. And it might end up, if you are in a position where you're trying to gather more information on why your colleague or why your trainee is not performing the way they used to, and you're seeing a lot of these behavioral problems, the conversation might turn into something more personal and something where you find yourself learning a lot about why this person, isn't showing up to the lab or the research group on time, and why they're missing work, and why they're behind on all the time frame goals. And those are the situations where we want you to be armed with some of these tools so that you can proceed in a way that could potentially really get this person help. So if you're in that situation, you might say something like, it sounds like you're having a hard time. Can you tell me more about how you are doing? You have two paths at this point. You might have someone who's just general venting, and they have support and they have coping strategies. That might sound like, my work product hasn't been the same because it's just been so overwhelming. And, I just moved here from out of town. I'm having a hard time making friends and I'm adjusting. And in that type of conversation, you're still going to hear hope. You're going to hear, oh, well, good thing I, can rely on my partner, or good thing I have some friends in the lab. You're hearing a sense that things are hard, but things aren't hopeless. This person still can see some kind of a path forward. And when you see that in this conversation and you don't have some of those other risk factors Dr. Horowitz pointed out, right, then it's much more likely that the type of conversation you're having is one where you don't have a real clear risk for suicide. And in that situation, it's always beneficial to listen, to validate, which means, wow, it sounds like this is really hard. How can we work together to kind of repair maybe some of these issues we're seeing in the lab? You can offer support, and you can always refer to mental health resources. That'll be an important part of our conversation today too, is having those resources kind of on hand in your back pocket so that you can help people make connections. Now, the other side of this conversation can look like real hopelessness. And when you have a situation where you have a colleague or a mentee who's really drastically changed their behavior and they're not showing up at all, and they're really disengaged and they've really changed drastically, they don't have any connections anymore. And then you hear things like, there's no hope, and I don't have anyone to talk to. I don't have anyone in my life. I don't see any path forward. And you're hearing real hopelessness and real kind of lack of any solution. That's where you might find yourself wanting to ask about suicide risk, because that person is more at risk. And thinking in terms of the total picture is important here. Thinking in terms of those risk factors is important, but if you don't know a lot about those risk factors, but you're in a conversation where someone's just really hopeless, it might be a situation where they can open up to you and you can ask them about suicide risk. So let's go to the next slide. What might that look like, right? You're in this conversation, you're feeling like this person is really in rough shape, it's sounding really serious, it's sounding risky. These are some of the sentences and statements that you can use. The starters are kind of different, but I want you to note that again, the main question, are you having thoughts, or are you thinking about killing yourself, is direct and straightforward. We don't want to say, are you thinking about hurting yourself? Because hurting yourself is different. Self-harm is not necessarily suicidal ideation. And so we want to be clear and direct because we need to have clear and direct data that we get from them. So that's an important part. It's important for us to acknowledge, and you might want to acknowledge it. It's an awkward question to ask. it still can be life-saving. And I'd rather someone have this conversation in an awkward way and they read right off of, kind of a cue card like this than that they don't have it at all, where there's really an opportunity to potentially really direct someone, get them into a therapist's office or a psychiatrist's office. So in the event that you go ahead and ask the question, like I said, I have a lot of experience asking this question, awkward as it is, and almost everyone says no. And that's great, that's fine. In that event, then you say, okay, well, I'm glad you're talking to me about what's going on anyway. Most people in my experience don't get angry, they don't get extremely offended, they just kind of say, no, I'm not thinking about killing myself. And then you've asked, and then you still help connect them to resources because they're obviously struggling if you ended up in this conversation. If they say yes, then you continue the conversation. Next slide. So if they say yes, then you want to move on to the primary question, which tells us if this is risk or this is acute, serious, immediate risk. So either way, we know that they're at some kind of risk because they said they've thought about killing themselves. And now you say, are you thinking about killing yourself right now? And this part in the decision tree tells us, is this an emergency that needs immediate help? Or is this a serious problem that needs help, but it doesn't have to be immediate? The difference is if someone tells you that they're thinking of killing themselves, yes, right now, then you ask some of the other questions that'll be on the next one of the next slides, but then you know that you have to get them help immediately. So let's go to the next slide, which is the action steps for how to help someone in emotional pain. And this is kind of the general guidelines for the steps that you want to take. This is the path we're following. Number one is ask. And that's what we're talking about. If they're an acute risk, then you're keeping them safe and you're making sure that you connect them immediately to emergency services. Being there is part of the conversation. If you're waiting with someone, you then help them connect. And then the last step is that you sort of follow up and stay connected with this person. So let's go to the next slide. In the event that you've gotten a yes all the way down this decision tree and you are trying to determine if this is, yes, I'm an immediate threat, then these questions will just give you more information about how intensely risky the situation is, because all of these questions just increase the seriousness. And the difference between someone who says, yeah, I have thought about killing myself recently, might then say, yes, I'm thinking of killing myself right now. They then might say, well, no, I don't have a plan. And I don't know that I would actually do it. I've never done it. I've never tried. I've never, you're kind of gathering more information about how big of an emergency is this? It's always worth following up with. It's always something to be respected, and we always have to pay a lot of attention if we get in this conversation, but we don't necessarily have to make emergency steps. So let's go to the next slide where we then talk about those two different levels of risk. Non-acute suicide risk is not an immediate plan to kill themselves, but they have thought about it recently and they may be at risk. So you still definitely want to connect to resources. It's always a good idea. I highly recommend trying to gather as many numbers and resources as you can and have them on your person, have them on your phone. 988 is the new suicide helpline number. We can always hand that out. Yeah, it's working nationally from everything that I understand. There's a question in the chat. But you can always benefit from handing that out to someone who's in a lot of emotional distress, making sure they have that. A lot of people just don't know it exists. You could be helpful just by connecting someone to that. If you have an EAP or counseling center at your institution, find out what it is, find out who you can talk to there, find out who you can connect with there. A lot of counties have crisis intervention teams that aren't quite, an emergency room, but are specifically for emergency issues that are more mental health related. find out what those are. Keep that information kind of in your back pocket, because you can always give it to people, and that can potentially really make a difference in someone's life. Now, acute suicide risk, in the event that you have determined they are an immediate threat, they have a plan and means and have the potential to kill themselves on this day, today, and you've gotten yourself into this conversation, which is very scary, and I recognize that. In that event, you don't just hand them the resources, but you make sure they access one of these resources, meaning, okay, you have them call the suicide crisis number in front of you, or you have them, they guarantee you that they're going to go straight to the emergency room, and they confirm that with you. You don't let them leave your office until you've made sure that they are leaving your office and immediately going to obtain emergency services. So not, a meeting with a therapist in 2 weeks, but you keep them safe. And worst case scenario, if they run out of your office and they leave, you have to call 911 in that scenario. You have to do what you can to get them into emergency care right away. So again, just to reiterate, we're not asking you to be that emergency service. We're asking you to potentially identify where someone needs emergency services and then handing them over to someone else. You're not solving the problem. You're not attempting to fix this. You're simply attempting to maybe help someone who needs help and won't access it otherwise. So next slide. In this conversation, another just kind of set of good skills that can be really helpful in these conversations is, just practice active listening, which is a skill where you just let the person talk and you listen and you don't interrupt and you don't try to fix the problem, but you really just give them an opportunity to talk about what they're going through. And that's how you might find out that someone's in a lot of pain, is by just being the person that listens to them and lets them talk about what's going on for them. And again, just being there for someone, being a person they can be open and honest with, can really make a huge difference. And a lot of people don't have anyone in their life that's able to do that for them. All right, the next slide is kind of about following up. So remember, the step 5 of the 5-step action plan is sort of staying connected. So let's say that someone in your lab or your research group or a mentee, goes and seeks emergency help, and then they kind of come back to the lab. You connect them with resources and you follow up, and you're just sort of a point of contact. Being able to have conversations with someone who's struggling, being open, can really make a difference and help keep someone safe, just by them having someone to that they know they can be honest with and that they can communicate with about the struggle that they're going through. Again, you're not solving the problem. You really just being able to actively listen to someone who's struggling can make a huge difference. All right, so the next slide is about kind of more the wider lens, the community-wide aspect. You may very well find yourself in a situation where, you're leading a group or a lab or a department, and there's a suicide within your community. So a lot of times people don't know how to manage that. Understandably, it can be really overwhelming and confusing. And we don't, the research does not recommend that people just deny that a suicide happened if one does, or ignore it. But it's important to kind of cope with this in a community, in a mindful way, in a way that reduces the risk of suicide contagion, which is a really real phenomenon, which just states that when there's a really highly publicized and irresponsibly publicized suicide in a community, we do tend to see higher rates of suicide than we would normally expect. And again, oftentimes that's more highly correlated with suicides that are publicized in an irresponsible way. So let's look at the next slide and kind of discuss what does an irresponsible discussion or reporting of suicide look like? It looks like a huge volume of reporting on the suicide with details of how a suicide was completed. Those details of how a suicide was completed, I don't think are ever helpful in processing with the community, the loss. And be careful to not attribute simple explanations. Suicide is a complex public health problem that never has one simple answer, right? It has a lot of contributing factors. So we find that when it's attributed to something simplistic, that can impact the community's coping. Be careful not to glamorize suicide. Always provide information for the helpline, crisis chat number in any reporting of suicide. There should always be access to connections to resources. Whenever suicide is brought up, it should always be mentioned that there are places to call, people to connect with if you or a loved one is experiencing suicidal ideation. And so that's just kind of some information about how to cope with this problem at more of a community level. So the next slide just has resources. I want to make sure that, again, that I provide those to you. I can't stress enough the benefit of having numbers in your phone, counseling centers, crisis centers, the suicide crisis line. If you click on that link, you can get little wallet cards. I keep those just small that you can physically hand to people. It's important for people to have that. There's lots of ways to get these resources out to the community. And as Dr. Horowitz said, looking at this problem from a perspective of hope that not all can be prevented, but some can be prevented with all of these action steps.
What is your box doing at the edge of your bed?
All right, so Jen, I think I'll hand it over to you. We have a little bit of time for questions before we move into small groups.
Lisa, we are really on time. Do you want to share your video?
Sure, it's about 2 minutes and 45 seconds.
Perfect, let's do it.
Okay. So this video that I'm about to show you, the reason why I want to show it is it's about kids talking about kids. It's a public service announcement from Mayo Clinic. And let's see, how do I unhide this, Patrick? Maybe. Here we go. And they let me use in my presentations, but really anybody can use it. And it's geared towards kids, but it's really everything they say hangs true for kids or adults. So here you go. And I just want to make sure that I optimize for sound so you could hear it. Hold on a second. Okay.
I have my ups and downs, just like anybody else.
Maybe more than anybody else.
I can be hard to figure out.
And I like my privacy.
I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual...
Acting really down, crying all the time for no good reason.
Or getting really mad, not able to sleep, or sleeping too much.
Shutting her friends out or giving her stuff away.
Acting reckless, drinking, using drugs, staying out late.
Suddenly not doing stuff he used to love.
Or doing stuff that's just not like him.
It might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed.
Not just feeling down, really depressed.
It might be that your kid is thinking about killing himself.
It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to me.
I wish he'd said something.
I wish I'd said something.
When it's too late. So if you think your kid's acting different, If she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask straight out. Are you thinking about killing yourself? It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask.
They want somebody to care.
Maybe you're afraid you'll make it worse if you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask.
In fact, the best way to keep a teenager from killing herself is to ask, are you thinking about killing yourself?
And what if they say yes?
Or maybe.
Or sometimes,
Well, here's what you don't say.
That's crazy.
Don't be such a drama queen.
you're making too much of this.
That boy's not worth killing
Yourself.
over.
That's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself.
What you do say is,
I'm sorry you're feeling so bad. How can I help?
We'll get through this together.
Let's keep you safe.
A lot of people think about killing themselves, adults and kids.
most of them never try it, but some of them do. So if your kid says,
I'd be better off dead.
I can't live with this.
I'm gonna kill myself,
Take her seriously. Find someone she can talk to about it. Someone who knows how to help.
Okay, I'm gonna stop it there. It goes on, and I encourage you all, if you just Google Mayo Clinic PSA and teen suicide, it comes up. But I stop it there because each one of us can be someone who knows how to help. So
Thank you so much, Lisa and Marin, for such powerful and important information, information that will help us keep our community here at the NIH safe, but also those external to our community. So with that said, we are going to open the floor. So if anyone has questions for Lisa or Marin, feel free to unmute yourself and ask that question or share in the chat.
While we're waiting for people to put questions in the chat, I'd like to ask a question a little bit about a reframing. So a lot of the discussion acknowledged the supervisory relationship in workplaces, and certainly mentors will have these types of conversations with trainees and with supervisors with staff. But a lot of times a friend is talking to a friend. And I just wonder if you could share whether you think there are real differences. I think that direct asking is probably exactly the same, but the responses, if the answer is yes, I think it's really important that we make sure friends know how to deal with this. So could you address that directly?
Yeah, I can talk about that. I absolutely think that if it's, someone in a friend role, the conversation can look the same. I think the steps in having the conversation are the same, and the same idea holds true. It's probably still going to be awkward. It's probably still not going to be a conversation that you are looking to have, but you're having it with somebody who you see is in a lot of pain. And really the take home point is that if you find yourself in a situation where someone appears to be at risk and you think they're really at risk, you can really help by just helping them see that there is a solution that they can access, because that isn't always so easy to grasp. When you're in a lot of pain and a lot of emotional pain, are very depressed, that's oftentimes when it's hardest to see a solution, right? It's hard for us to make decisions that move us towards a solution. And so oftentimes someone else just kind of helping you access that is exactly what somebody needs.
Thank you.
yeah, and I think what's important too is that no one has to feel alone with this. Like, so as you were asking that question, I was thinking, well, the supervisor. So, if you're the colleague who hears about this, you can go to the supervisor, but the supervisor has people they can go to too. So just no one has to feel alone.
Mm-hmm.
I think that's really important.
Thank you. There's a question in the chat. If you, I'll just read it for the two of you. What if a colleague, student, friend expresses non-acute or acute suicidal thoughts, but refuses to engage with mental health services? other than reconnecting, listening to the person and continuing to share, what can we do to help if the person does not want to engage?
I mean, the truth is that we cannot control other people's actions. And especially if we don't have reason to believe we're in an acute state of emergency, we cannot control whether or not other people choose to access help that we are trying our hardest to provide to them. And that's where we get into the, we don't have a perfect solution, but providing that guidance and making an attempt is always better than nothing. Sometimes it is just our best option to put it out there and hope that people follow up with it.
Thank you.
Anything you would add there, Lisa?
Oh, it's such a good question because it's so hard to help somebody who doesn't want to get that help, as Marin is saying. Some of us are what's called mandated reporters. So if you're a clinician and you hear it, you're mandated. But what if if you really think someone's going to die or kill themselves, then, as Marin said, you have to call 911 if you really think. Now, if they're thinking about it and they're talking about it, but they don't want to go for mental health help, then there's not much you can do. But if, and this has happened here even on campus. I mean, a lot of times when, as Marin said, when someone's in a suicidal state, right, they're just in unbearable pain and their brains aren't working right. They're not thinking clearly. So they're not using their good, what is usually good thinking is not there. And so you're trying to be that bridge to help them through this suicidal state. So if you can do that, that's even enough. If you can be with them through that, and that could protect them as well.
Thank you. There's another question. What does a visit to the ER look like for a person at risk for suicide? I do think there's a tremendous amount of fear around that, and it might be helpful for people to have a little bit of a visual image of what the experience might be like.
Yeah. Well, I can tell you it varies depending on the ER, right? So some of the best hospitals that have resources, probably people are going to have a better experience there. Someone, an ER, sending someone to the ER for suicidal ideation is never, it's already too late at that point. Like, it's better to intervene before that, because going to the ER, anyone who's been to an ER for anything knows you're going to wait a long time. You're going to be evaluated, and really what it's going to come down to is, do they have to put you in a hospital because you're such a danger to yourself, or they can send you home with resources, hopefully. So it's not the best option. People don't usually have a good experience with mental health if they have to go to the ER, but if someone is really at risk, that sometimes is your only choice.
Thank you.
Yeah, I would say my experience is that it's certainly an imperfect experience usually, and it's one that I really hope that societally will continue to improve upon. Real mental health emergency resources. It's the only option if you can't get somebody into a mental hospital, and it'll keep them safe. And sometimes that's the thing, is it'll keep someone safe who is absolutely in an emergency dangerous state. It'll keep them safe, and ideally will then connect them to more long-term solutions.
Thank you. Lisa, can I ask a research question?
Mm-hmm.
So I've often wondered why, like, say every laptop we get issued at our university or NIH, if like in the drop-down menu on the web, in the bookmarks, there were some mental health resources, wouldn't that be helpful? Like, it wouldn't take you know, it would just decrease the stigma, just like maybe links to NCBI are right there. Is there any studies that help universities decide what the quiet messaging, you know, what would be helpful?
Yeah, what a great question and suggestion. You know, every patient that's discharged from the clinical center at NIH is, no matter what you came in for, it has the suicide lifeline on. So things like that do happen. It is such a huge problem at universities, and it is still so hush hush. I have been shocked by some of the schools, even who have a suicide attempt or a death by suicide, that they still don't put the suicide lifeline on the back of everybody's badge. Why isn't it on the back of everybody's badge? I don't know of any studies. I know that if you call a VA, and the usual menu is, if you're a patient, press 1. If one of the options is, if you are having thoughts about suicide, press this number. And I think that's amazing. They just put it right out there. So
in
it's a great
terms of
idea.
the way schools struggled, there is a comment about how a student's school really struggled after a classmate died by suicide. And I mean, I think grief in general in the workplace is difficult, but so much more so when it's suicide. And I don't think we have a lot of resources to help. So it's a challenge. Jen, I don't quite understand the question in there. There's one last question.
Well,
Something
I see one about the plan. So I just want to reiterate that again, I always ask someone about a plan twice when I'm evaluating them. So I'll say, so if you were, do you have a plan to kill yourself? And they'll say no. And I'll say, well, if you were going to do it, how would you do it? And that doesn't, again, it doesn't put the idea in their head. It doesn't make them think. It's the answer you get. Sometimes you get a very detailed answer and then you're like, oh, okay, this is something you thought about a lot. And sometimes, you get something very vague and then the person hasn't been thinking about it in that detail. So you're not going to make them think of a plan where there wasn't one already. No, it's still okay to ask.
Right. Thank you. And of course, many times in the workplace, if we hear yes, our decision as non-experts would be to seek guidance right away and hand that person off, to somebody who was an expert, maybe not go into many more questions. But I think it's helpful to know where to go question-wise as needed.